Dr. Divya Srivastava.
Please, the slide with my name on it. The slide with my name on it. The presentation with my name on it. Dr. Divya Srivastava, the presentation. Second. Good morning, everyone. I'll be presenting on the topic, topical anti-inflammatory versus artificial tears in dry eye, long-term efficacy and side effects. So dry eye is a very common ailment with a prevalence of around 20 to 50% in Southeast Asian countries like ours. This makes it important to understand the role of ocular inflammation in its pathophysiology, wherein a vicious circle is created by tear film instability and the activation of inflammatory pathway. This warrants the use of topical anti-inflammatory drugs to curb the inflammation and not just topical lubricants, which replenish the tear film only temporarily. Earlier, the topical anti-inflammatory were used only in severe dry eye disease, but various studies in the recent past have started evaluating their use in mild to moderate dry eye disease as well. But a very few studies have compared the topical anti-inflammatory with the lubricating drugs. So the aim of our study was to compare the efficacy and safety of topical chloroquine phosphate 0.03%, topical cyclosporin A 0.05%, and topical sodium hyaluronate 0.18% in mild to moderate dry disease. Two of these drugs are topical anti-inflammatory and one is a lubricating. These are the objectives: to assess the demographic parameters of a subset of population in North India with mild to moderate dry disease, to assess the correlation of digital screen time with the prevalence of dry disease, to assess and compare the change in various dry disease parameters with the use of these three drugs, and also to assess their safety profile. It was a prospective comparative study which enrolled 105 patients aged 18 to 75 years with mild to moderate dry disease, presenting to the outpatient department of RAOP GMS Rohtak. Ethical clearance was obtained and the study was conducted for a period of 1 year. Patients presenting with various dry eye disease symptoms were subjected to a battery of tests, which included the ocular surface disease index score, tear film breakup time, Schirmer's test, and corneal fluorescein staining. Patients with only mild to moderate dry disease were included in the study, and any patient having a previous history of ocular surgery or trauma in the last 6 months or any ongoing current ocular disease, patients having known hypersensitivity to the drugs in study, patients with uncontrolled systemic disease, pregnant women and lactating women, these were excluded from our study. Patients were divided into 3 groups, and group 1 was started on topical chloroquine phosphate 0.03% twice a day, group 2 on topical cyclosporin A 0.05% twice a day, and group 3 on topical sodium hyaluronate 0.18% 4 times a day. The patients were followed up at 1 week, 1 month, and 3 months, and the battery of tests were repeated at every follow-up visit. SPSS version 26 was used, and the level of significance was set at p-value less than equal to 0.05. These were the observations. The mean age in group 1 was around 35 years, group 2 39 years, and group 3 34 years. The maximum number of patients in our study were in the age group of 25 to 50 years. Amongst the affected individuals, females were slightly more than males in our study. This study also recorded the digital screen time of all the patients, and it was found that maximum patients had a screen time of more than 6 hours, followed by 3 to 6 hours. The patients in our study presented with a variety of symptoms, but the most common symptom noted were gritty or burning sensation, light sensitivity, and difficulty in screen work or TV watching. These were our observations. TBUT of right eye, left eye, Schirmer's results. Corneal fluorescein staining test was negative for all our patients at the baseline and every follow-up visit, so it did not give us any inference. And these are the side effect profile. So our results were, on comparing the OSDI score of all the 3 groups at baseline, there was no statistically significant difference, but at 3 months, the OSDI had a significant difference between group 1 and group 3, which was chloroquine phosphate and sodium hyaluronate, and group 2 and group 3, which was cyclosporin A and sodium hyaluronate, whereas no difference was noted between group 1 and group 2. Similarly, for the tear film breakup time test, baseline had no difference, but at 3 months, the OSDI score between 1 and 3 and group 2 and 3 had a statistically significant difference, whereas no difference was noted between group 1 and 2. Comparison of Schirmer's test of all the 3 groups at baseline and at all the follow-up visits did not give us any statistically significant difference for any of the drugs. And the side effect profile at the end of 3 months was noted to be only mild irritation for 5.7% patient in group 1 and 2.9% patient in group 2 in our study, and none of the patient in group 3. And majority patients, 97.1%, had no side effects noted for the period of 3 months that we tested. So we concluded that topical anti-inflammatory drugs like topical chloroquine phosphate 0.03%, cyclosporine 0.05 have a significant benefit in the management of mild to moderate dry disease, which was noted by improvement in the subjective tests like OSDI score as well as the objective tests like tear film breakup time. However, when we compared the topical chloroquine phosphate and topical cyclosporine A, no significant difference was noted. This study also noted that no significant side effects are there with the use of any of the drugs in majority of our patients. Hence, topical cyclosporine A and chloroquine phosphate are efficient and safe management options in patients with mild to moderate dry disease, and these in combination with topical lubricating drugs can give early and better symptomatic improvement. And as ophthalmologists, we should start prescribing these drugs in mild to moderate patients, which form a majority of our subset of patients in our OPD. Limitations were a relatively small sample size, the fact that study was conducted in a single center, and diagnostic protocols employed were limited due to availability. There were no financial supports or conflicts of interest in my study. Thank you so
much. So what was the criteria for you to allocate these patients into the 3 groups?
Ma'am, we randomly allocated the patient, systemically allocated the patient into 3 groups. As the patients were coming in the OPD, systemically the patients were allocated, one in group 1, then group 2 and group 3.
So what is the difference when you say mild or moderate dry eyes? You know, because one of your drugs is taking care, like sodium hyaluronate is taking care of the symptoms, while the other 2 are taking care of the pathogenesis. So first, the mechanism of action is completely different, and mostly the anti-inflammatories are added to the tear substitutes. So how did you kind of compare and came to this conclusion that you mean to, from your study, if we go, any patient coming with mild dry eye disease should be started on cyclosporine A instead of any regular tear substitutes?
Ma'am, we tried to compare this fact only, that there has never been a comparison between using only topical lubricating and using these drugs adjuvant to that also. We can use adjuvant, but we tried using it
primarily.
Just to compare, so that we are not using a lubricating, still we are getting benefit in dry eye disease patients in mild and moderate cases both. So we did not add a lubricant or adjuvant to this drug to compare it.
Do we have specific chloroquine topical preparations?
Yes, sir. Chloroquine phosphate is available in 0.03% topical. Yes, sir, in the market.
So, but in your study, if a patient with mild dry eye disease, we start on cyclosporine directly or we start on sodium hyaluronate, he's going to respond to either.
Yes,
so why should we ask the patient to pay 10 times the amount for a mild dry eye disease, which could be tackled with a simple tear substitute? Because the results, according to your sample size, is more or less the same. So that is what my question is.
Ma'am, because right now also we have been following up the same patients. So we have observed that patients who we started on the anti-inflammatory therapy, at the end of 3 months, there was significant reduction in both signs and symptoms in comparison to the lubricating drugs. Lubricating drugs, mostly we have to give more chronic than the topical anti-inflammatory. So
Why chloroquine? Any immunological reason?
Ma'am?
Why chloroquine? Why eye drops? Any immunological reason is there?
Ma'am, it's an anti-inflammatory, topical anti-inflammatory
What she wants to ask is, did you categorize the patients whether any of them had Sjogren's or history of rheumatoid arthritis or keratoconjunctivitis?
Actually, any systemic or uncontrolled systemic disease were in our exclusion criteria. So only mild to moderate disease patients were included. We excluded those patients.